Why do spinal anesthesia or spinal tap fail? Now, failure to accomplish spinal anesthesia or spinal tap can really throw a wrench in the patient management process. And if it happens often, it can also lead to the scrutiny by the colleagues and such. Needless to say, it's really important to be aware of the causes and techniques to prevent failures. But why do they fail? The anatomy is usually straightforward to palpate and identify. The technique of needle insertion is simple and easy to teach. And the presence of the CSF acts as both as a definitive endpoint for needle placement and as a medium for conduction of the local anesthetic to the sites of action within the subarachnoidal space. For successful spinal anesthesia, two conditions must be met. Number one, we need to puncture and introduce the needle tip inside the dura mater. Number two, the injection of the entire dose of the planned anesthetic agent must occur in the subarachnoidal or intrathecal space. And despite the theoretical simplicity, failure of spinal anesthesia is not uncommon, and in the older literature it was reported to be as common as 17% of the time. Now, of course, clearly this high failure rate from 1985 paper would be inconsistent in the modern practice of regional anesthesia. Indeed, with modern techniques and equipment for spinal anesthesia, the failure rate is much lower. It is about 3.2%. The greater number of puncture attempts and not using adjuvant medications such as opioids with the local anesthetics are independent factors associated with the greater risk of the failure of spinal anesthesia. An ideal placement of the spinal needle into the intrathecal space is illustrated in here. Here we can see the entire opening of the port of the needle inside the intrathecal space. And when the local anesthetic is introduced through that space, clearly it acts on the fila terminale and the conus medullaris. This is where the local anesthetic actually works. When the needle is introduced like this, then what you get is a flow of the CSF outside of the needle, and the injection of the local anesthetic occurs inside the intrathecal space. Sometimes the needle does not make its way entirely into the intrathecal space. And sometimes you can get the dural and subarachnoidal flaps that prevent the successful spinal anesthesia. Let's talk about that. So here we have a situation in example A where the needle tip is introduced into the intrathecal space. However, there is a dural flap that obstructs the needle partially. It's quite clear that you can get the CSF outside of the needle. However, you may not be able to aspirate it. So every time when you cannot aspirate through the needle, there may be a higher chance of the failure of the spinal anesthesia. In this situation, an injection through the needle can occur partially into the intrathecal space, but also partially into the epidural space. And clearly, in this situation, a small amount of local anesthetic that is used for spinal anesthesia, when injected into the epidural space, would be a failure to accomplish a spinal anesthesia, which occurs only here. In the example B, what we see is the opening of the needle is now straddled partially by the dura, and it's also straddled by the subarachnoidal tissue. So in this situation, as you rotate the needle, you may be able to get the CSF flow back to the needle, but an injection of the local anesthetic through the opening may or may not occur inside the intrathecal space. Again, it can occur partially intrathecally and partially epidurally or subdurally. In both of these instances, an injection of the local anesthetic either into the epidural space or here into the subdural space would not result in a successful spinal anesthesia. And here's another example. In here we can see the needle insertion into the intrathecal space, which is a complete, and here the injection clearly results in successful spinal anesthesia. Whereas this insertion of the needle, where the needle is partially inside the intrathecal space and partially in the epidural space, here you can get a CSF flow, which could be deceiving, but an injection of the local anesthetic can occur either inside the intrathecal space or into the epidural space, which would result in a failure of the spinal anesthesia. And let's go to the infographic in the Compendium of Regional Anesthesia. Here are the main mechanisms of this failure of spinal anesthesia. Here we have broken all the causes of the spinal failure, into the 4 categories. Unsuccessful lumbar puncture, which we have talked about in our other YouTube videos, so we encourage you to look for other topics on spinal anesthesia. These are the solution injection errors, which we will talk a little bit more about. This is the inadequate intrathecal spread, which is not a topic of this video, but we will cover this in another one, and a drug failure. But let's go and focus on the solution injection errors. So one of the most common ones is the loss of the injectate. In other words, as you connect your syringe to the spinal needle, once you get a CSF on the other side of the spinal needle, oftentimes it happens so that the local solution leaks from the connection between the syringe and the needle. Clearly, this has to be made up, otherwise we will inject insufficient drug amount or dose inside the intrathecal space, which will lead to the failure. Number 2, partial injection. Partial injection occurs, as we talked about, when you have a mechanism in which the needle is partially inserted into the intrathecal space and partially connected to the either subdural or the epidural space. In that case, you may get a CSF back, but your injection of the local anesthetic under high pressure, which typically occurs through these needles, is partially goes into the intrathecal space where it works on the neural elements, but partially goes subdurally or epidurally, which leads to the failure. And finally, you have a flap valve effect, which we talked about earlier. So these are the main causes of the spinal failure. I encourage you to read the complete lesson on failed spinal anesthesia in the NYSORA's compendium of regional anesthesia, and would love to hear your feedback and discussion on the most common causes of failure of spinal anesthesia in your institution and what you do in your practice to prevent the failure. And if you like our content, be sure to subscribe to NYSORA channel. Until next time.